in genetics. But I do practice cancer genetics. Not only I talk to patients, I also sign the report for cancer genetic NGS testing. So this is what will happen today when you're training. The basics have to be good. 10 years, 20 years, 30 years down the line, you may be doing something which is not, as part of your degree, but that has happened if it is required. And like many top cardiologists, when they trained, there was only ECG, there were many other things that were not known. But as you go into your profession, as you practice your profession, whatever is needed for your patient, you learn that, and you develop not only the knowledge but the skills and the finesse and understand the nuances. So I will try to give the background of this. So to begin with, what are the genes, chromosomes, and alterations? So, we have human chromosomes. Genes are the functional unit of inheritance, and they are not just any stretch of DNA. They have a specific structure and sequence of nucleotides. So the start codon, the stop codon, and this directs the synthesis of a specific chain of, polypeptide chain, which we call protein, and proteins have biological function. And any genetic material or things which regulate genetic expression may be altered, and whenever that happens, it may or may not cause a phenotypic effect. So that's what we'll talk about. So chromosomes, and there chromatin loops, then the DNA is tightly sort of wound around the histones, and then you have this is what you see, the double helix, the ATGC, the pairing of the four nucleotides, and essentially the language of nature is just with these four nucleotides, how they are arranged, the sequence in which these nucleotides are arranged. So whenever you have genes or genetic material, there could be alteration. So I think as clinician, I look at the ECG, it's otherwise to a lay person, it just looks like some lines going up and down. But many of us can understand what it is, what actually it's worth taking a note and acting upon. So in genetic alteration, sometimes you have a chromosomal abnormality. That means there is a breakage of a chromosome or duplication of a chromosome or deletion of a chromosome. And whenever a whole chromosome is abnormal, it will almost always have some phenotypic effect and often a disease or an abnormal. Then you could have abnormality in a single gene. So it depends upon what gene it is. Some of the genes have redundant function, or there are many other genes which do the same function, or there are many genes of the 25,000 genes. About function of those genes is still not well understood. But if it is an important gene, a large deletion or duplication, that means parts of exons or introns are either deleted or inserted or duplicated, it will almost always disrupt the function of the protein that is coded by the gene, and it will be pathogenic. Pathogenic means it will cause a pathology or the risk of developing a pathology. Then small insertions or deletions, which you call indels. That means few 1 or 2 or 3 or 5 or 6 bases, nucleotide bases either inserted or deleted. So it could be an in-frame deletion. So whenever I am writing in red, that means it will be pathogenic. When it is green, that means it may not have any biological consequence or disease risk. In-frame means that the reading frame, the codons, just basically 1 or 2 codons. So it will be multiple of 3 and starting from the one codon. So you may just have one amino acid missing or added. It does not always cause change in the protein to the extent that it will cause disease. So it may or may not have a pathogenic effect. Whereas it's a frame shift, insertion, or deletion. So frame shift means the reading frame is changed, and as a result, somewhere down the line, a stop codon is introduced. So whenever a stop codon is introduced, then during the process of transcriptions, translation, so the whole protein will not be formed. It's a truncated protein. And just imagine a machinery which parts, major parts missing, it will not function. So same way, the protein which is a truncated, it will not be able to do its job, and it will be pathogenic. The thing which comes and sometimes is a single nucleotide base, that is just one place. Instead of a T, it is a C, and as a result, sometimes even the nucleotide changes, but the amino acid coded is same because of the degeneracy theory. Many different combinations code for the same amino acid. So these are called as silent or synonymous variations. So most of them have no consequence on protein function and this thing, and they are SNP, single nucleotide polymorphism, but sometimes they could affect the splicing or some other reasons. Then missense. Missense means it is sensing for another amino acid. So these terms are important because you will read them in the reports. So instead of, let us say, threonine, now you have alanine or some other amino acid. So most of these, in most of the proteins, just change of one amino acid is tolerated. It does not affect the function to the extent that it will cause a disease. So they remain single nucleotide polymorphism. Sometimes they may have a weak risk association that you will find from case control study, or they may be of pharmacogenomic relevance, but doesn't really directly cause the disease. But sometimes some of the missense variation, because they alter a very important critical part of the protein, so it will affect the protein folding or the shape or something else that, and if they're in the DNA binding domain, they could become pathogenic or disease causing. And the rest of the missense variants, if we do not know whether we cannot classify them either as benign or likely benign SNPs or pathogens, we call them variant of uncertain significance. Then the splice site. So there is a conserved splice site, exon-intron boundary. During uh, the process, the introns are spliced out and the exon are the coding region, so they form the protein amino acids. And so if there is a variation or a mutation in the splice site, then you have a aberrant splicing. So that means part of the intron or exons are retained or duplicated and in the transcript, and that will affect the protein function. They are pathogenic. And nonsense means, like missense is they're sensing something else. Nonsense, that means they're not sensing anything further, and it's introduction of a stop codon. So you either gain a stop codon or you lose a stop codon, and they're almost always pathogenic because proteins duplicated. So the missense and inframe indels, if they are rare in the healthy population, if they are SNPs, you would expect they are present in 1% or more of the population. They are variants of uncertain significance, clinical significance. And if in absence of functional characterization or co-segregation studies in large families, they are called as VUS, and they pose a challenge in counseling these families. So as you will gain confidence, you will start looking at these VUS, trying to make sense of it. And believe me, if you actually apply your mind, many times you're able to make some sense out of it, and you are able to counsel the families, because some they are called as VUS, but in this clinical context, this VUS, maybe it's an unrelated gene or some other description in there that it is unlikely to be disease associated. So what is genotype is our genetic constitution of an individual as applied to either one locus or all the loci collectively. And when we talk of the entire genetic constitution of an organism, then it is genome. So you could have a rice genome, mouse genome, human genome. So what is phenotype? So phenotype is the appearance or observable nature, and it is the effect of gene environment interaction. So here I show you these are two autosomal recessive genetic conditions. This is an albino who had skin cancer, and this is a patient with a xeroderma pigmentosa XP. He also has skin cancer. The underlying genetic effect is different. There's lack of melanin pigment, more of UV rays goes. There's actually overproduction of melanin to protect the UV rays from coming. But there's a defect in the DNA repair gene. That's why more of DNA damage happens because of UV, and they develop skin cancer. So ultimate result in skin cancer, but the mechanism is underlying mechanism is different. And this is, I've shown the black and white, but there are many gray shades. And I think as doctors, we are basically phenotypers. You may or may not be a genotyper. You may or may not understand the genes and genotype, but at least phenotype and the shades of phenotype we have to understand. That is how the branch of medicine has grown. And I think that's only our job. I mean, the lab person will not know. They would rather depend on you to describe the phenotype of the person, the face, the bowel, and everything else. So cancer is basically a dysregulation of the most fundamental biological process, and any factor which governs the replication and integrity of cellular phenotype actually can suppress or accelerate development or progression of cancer. So, this looks a little odd when they say that all cancers are a genetic disease, because genetic alteration, whether in genes or chromosomes, are a hallmark of cancer cell. No one has ever seen a cancer cell which has all the genes and chromosomes absolutely normal, and the defect is only in the cell membrane or mitochondria or some other thing. So cancers are genetic disease, and the term genetic refers to somatic genetic disorder. So almost always cancer cell has, not almost always, always, and it is not the hereditary or germline genetic disorder, which is there only in 5% of cancer cases, and we will talk about that. This is a term which you would read sometimes, penetrance. So penetrance is manifestation of a phenotype. 100% penetrance means all those who have the gene alteration will develop the phenotype. And 5% penetrance means only 5% of those who have the genotype will develop the phenotype. So we talk about the high penetrance gene. That is what we'll talk in this lecture. Like P53, BRCA, retinoblastoma, red gene, which have a very high lifetime risk of developing the phenotype, which is the cancer here. And then low penetrance genes, which are basically SNPs like GST, CYP, SARL. So they have less than, so they have a risk association. They are not causal. So the pattern of inheritance, why I'm showing this is dominant. We're talking of Mendelian inheritance. So mostly we're dealing with autosomal dominant conditions. Very few are recessive, like I showed XP and albinism, and few syndromes like CMMRD and MYH associated polyposis. There are very few cancer predisposition syndrome which are recessive. Most others are autosomal dominant. We don't have a sex-linked syndrome, and some doctors are still, they ask questions whether can the BRCA mutation come from the father's side. It is not sex-linked. It is not an X or Y chromosome. It is on chromosome 17, BRCA1, and BRCA2 is on chromosome 13. And sometimes it looks like a non-Mendelian inheritance because of incomplete penetrance or other factors. So this is something which all of students, I think the current lot of students, because they are taught during their MBBS, they know about proto-oncogene, tumor suppressor genes. Simple way to put it, a proto-oncogene will cause a disease when only one allele, we have prologous, we have pair of gene. Only where tumor suppressor genes, both alleles are affected. The effect of mutation is enhanced, or what we call as a activating mutation or gain in function or dominant mutation. Whereas here, this is loss of function or inactivating mutation. And it is recessive at the cellular level. That means both other copies also has to be lost. So this is the main difference. And if you try to remember how it works, this is like a car simulator. So imagine oncogenes like accelerators. You only one accelerator in the car. And just imagine it is stuck in full throttle. So this is what is oncogene, and the car will go out of control. At some point of time, you will have an accident. So this is what like red or HER2 like that do. And tumor suppressor genes are like brakes. So some of us don't remember there are two brakes. One is the foot brake, other is the hand brake. So tumor suppressor genes is also have two. So one you may be born with, and the other one goes this way. And if you have mutation in oncogene, gain of function mutation in oncogene, or loss of function mutation in a tumor suppressor gene, then you have a very high lifetime risk of cancer. This is a textbook of oncology Tata Hospital is coming out with. I've just shown a table in this. This is the name of the gene. This is a syndromic feature, which cancer they could develop. I mean, it will be such a punishment for students that try to remember all this, and no one can remember. Even after writing that, even I cannot remember what all. And these are two. This is first, so it's a big table. This just shows that you don't have just one gene and one cancer or one syndrome. So for a particular cancer, there could be so many genes which could be muted, and for a particular gene, there could be different cancer manifestations. So it is, I'm just showing it not to intimidate, but to say that it is not possible for anyone to remember everything. You may have a short note or something, and if that is coming for many times, people will remember that. Otherwise, it's not possible. Then there's a famous syndrome known as Lee-Fraumeni syndrome. You look at the criteria; they keep on changing. So classical Lee-Fraumeni syndrome, then Birch criteria, Compret criteria, Eales criteria. I mean, ages and who all are affected. It's not possible to remember. So why I'm showing it is just to say that Of course, in the genetics clinic, it's a specialized clinic, but a practicing clinician cannot remember that. So why? I'll come to that. So what is the remedy? But you need to know. So what is the remedy is, I'm showing this gentleman photo. His name is Alfred Knudsen. He uh, wanted to be a mathematician, then became a doctor, pediatrician, scientist, and finally into public health. So he published many years ago, more than 50 years ago, his two-hit hypothesis of cancer causation. And this actually explained relationship between hereditary cancer and sporadic cancers. He proposed a mechanism of penetrance in hereditary cancer, and he predicted existence of tumor suppressor gene. And this was not known at that time. And this is recognized as a very major contribution for understanding all forms of cancer, including what happens at the tissue level and at the tumor level. So he, as a pediatrician, I mean, it was common knowledge that retinoblastoma, which is a childhood malignancy, it was well known that it could be either familial or non-familial. It was also known that familial ones, more often than not, they are bilateral. And so this was well known. So he started with this knowledge. And when there's a bilateral, you can assume it is familial because of some genetic cause. And if it is sporadic, if it is unilateral, more often than not, it is non-genetic. So what he did is he plotted the age. So this is percentage of cases not yet diagnosed at age indicates. So age is in months, and this is this thing. So and these are the bilateral cases and these are the unilateral cases. So what is important? Because he wanted to be mathematician, and many of us, we become doctors because we don't like mathematics. So he plotted a semi-log plot. So this is age is, it is linear and this is log. So, the percentage 1, 2, 4, 6, 8, 10. So what you see, this is a straight line and this is a line with a shoulder. So this would happen. That means so that one event has already happened and just one event is required, you will have a straight line. And here two events are required. That's why you will have a curved line, a shoulder, and then a straight line. This is also we do in radiation oncology in linear quadratic model. So this is the linear quadratic this thing you use. So how he explained that? So imagine there are two forms of cancer and nothing to do with retinoblastoma, any hereditary cancer. In hereditary form, and as I said, I did not mention that, except for rare exception of proto-oncogene causing hereditary cancer like RET or some other, almost all hereditary cancers are because of tumor suppressor genes. So hereditary form, the first hit is inherited in all cells. So if you see this cross I've made, in one copy of the gene you have the mutation, whereas in sporadic form, at birth, all the cells are normal. In all the cells of the body have no mutation. Then in hereditary form, just second hit happens in few cells of same or different organ. It may happen just in the retina or some muscle cell. Whereas in sporadic form, the first hit is in one or few cells. So that is happening because mutations are probabilistic, even it can happen. Then second hit is in one cell. If the same cell in sporadic form happens the second hit, then that is transformed. Whereas here, because every cell had a single hit, the second hit is very common. So clonal proliferation of several transformed cells in one or both paired organs. So that's why in hereditary form, very often you get multicentric cancers or bilateral cancers or multiple primary cancers. So that is one feature of hereditary cancer. The second is because they get a lead time in origin, so they tend to occur in an earlier age. Whereas here, because, and this will be very common. So anyone born with first hit has a very high lifetime risk of developing a second hit and the cancer because the mutation is present in every cell of the body and mutations are probabilistic event. Whereas in sporadic form of retinoblastoma, the same retinal cell has to undergo both the hits and then develop. So this Knudsen's hypothesis explains it all. And now we know because the hereditary forms of a cancer is driven by a particular genetic pathway. And that's why they may have organ specificity. You may have specific immunohistochemistry feature or a molecular marker or a syndromic phenotype because that gene or pathway could also be affecting some other features. So you may have a syndromic phenotype. So this is, I think if you remember that hereditary cancers tend to occur at a younger age. More often they are multicentric or bilateral or multiple primary. And because it is hereditary, it is born, you're born with the first hit. This hit is present in every cell, including germ cell. you may have a family history. So I think if you remember that, you can go. So I think I'll just come to directly ordering and interpreting genetic tests. So first and foremost, to know, is it indicated in a person? So should know the guidelines. Again, there's so many guidelines, they keep on changing. It is not possible to remember. And many of you would be practicing broad specialties, not just one particular organ system. So just remember the nuts and screw it hypothesis. So anything which is happening, the family history occurs at a age which is younger for the typical age for that cancer, malignancy, is bilateral or multiple primary cancer, or has some feature in the immunohistochemistry or molecular or syndromic feature, you should consider genetic testing. Then who in the family should be tested? Ideally, the person who has cancer and the typical cancer for that syndrome. What is the best sample for genetic testing? It is on a blood, the DNA you extract from the lymphocyte, but even mouthwash sample could do. Sometimes you get confused, you should do germline testing or somatic testing, or both, or one after another. So except for some cancers, generally, here we're talking of the germline testing. Actually, the data even for the precision medicine, for PARP inhibitors and other for immunotherapy, the strongest data is for those who have a germline mutation. And what you should test, just if a mutation is known in the family, just that mutation, or a hotspot mutation, or 1 to 2 genes, or large genes. And actually, by the time you all are in full practice of professors, many patients will be coming with whole exome sequencing. Then finally, how to interpret the result. So it should be pathogenic or likely pathogenic variant, what we call mutation. Benign or likely benign variant, that means of no consequence. Most labs would not report it, but some labs would confuse you, will give you a long list of variants. And then VUS, as I mentioned, and no variant is reported and family mutation not identified. So these are things you have to say. And as a doctor, it is your responsibility to see whether to suspect inadequate testing or reporting, because you only will guide the patient to do that. And sometimes you have to order additional tests. So in South Asia, we are 1/4 of the world's population, and even if you take just few percent of all cancers are hereditary, we have over 50,000 familial cancers in the country, and if you imagine just 3-4 members per family who require counseling, testing, and risk management, you would have 200,000 patients. Imagine few Tata hospitals catering only to this population. So that is not possible, and unfortunately, we don't have many comprehensive units. When I say comprehensive, clinic, the lab, counseling, and risk management. So many of you hopefully would start this, and so oncologists need awareness and training like you all are listening, and ultimately there should be mainstream. So genetically, this is something I've drawn on the blackboard, that you can actually detect cancer if you know and prevent it by drugs or surgery. I won't go into the details of the surgery. So these individuals who are genetically predisposed, they are eminently suited for early detection or prevention because they are very high lifetime risk. But in low and middle income countries, including India, despite being aware of their family risk, very often they present in late stage. Only a few receive genetic counseling. Clinical and molecular syndromic diagnosis is seldom made in pre-symptomatic stage and even after cancer diagnosis. Penetrance estimates are not, people are not knowing, and the issue of cost, access, and compliance to high-risk screening and preventive surgery. We at Tata Hospital now every day see 5-6 new families and many cases who come for follow-up. Like before the pandemic, we were seeing 1,500 new hereditary cancer families. And again, this year, again, it is back to the same. And this is a long list of syndromes. This is my old slide. Almost any cancer could have a syndromic or hereditary form. And of course, Hboc and Lynch syndrome are the most common hereditary cancer syndrome, but a long list of hereditary cancer syndromes. So what happens in genetics clinic? So first is the pre-test counseling. Then in that you decide whether genetic testing is required and understand all the issues. Then do genetic testing using a lab and a technique which is appropriate. And then the post-test counseling, which is very important part, because disclosing genetic test results, providing support, and helping them make plan for the next step. Many times you have not done pre-test counseling, you have not ordered genetic testing, but the patient will come to you with the genetic test report because you are the doctor and you are in a higher center, and you have the name and fame, so they want advice from you. But to begin with, someone has to suspect inherited predisposition and refer the patient for counseling. There are many ethical and legal and social implications. So each one point I would like to say is that each family and each person is different. You have to really deal with them and understand and address the issue. So genetic testing should be done only after genetic counseling of its pros and cons. Most clinicians are now realizing its importance, and at least the basic counseling you can do if you're not. And if there are a lot of concerns, you can refer them. Then there are principles of genetic counseling: autonomy, empathy, beneficence, non-maleficence, non-directiveness, informed consent, confidentiality, and fairness. And in our Indian practice, very often they are breached, but more often than not, there are consequences of non-adherence to these principles, not just for the patient and family, but sometimes for the physician also. So I think imbibe them and practice them, it helps. As doctors, we make diagnosis and differential diagnosis. Same is true for hereditary cancer syndrome. That depends on type of cancer, age of cancer diagnosis, unilateral or bilateral, multiple primary cancers, histology, who are the affected, and phenotypic features. So making a good clinical pathological based syndromic diagnosis, looking at polyps, skins, eye signs, cysts, it helps in family is unable to do large multi-gene panel, even if they do large multi-gene panel in interpreting BOS in a particular gene. So like this is a patient I treated. So she had early onset bilateral breast cancer without a family history. Till one day she told me during radiation she had pigmentation. I told because radiation said no, sir, we have this pigmentation problem in our family, and she showed a classical, and her nephew also had. So this was a misdiagnosis of Peutz-Jeghers, and she gave a classical history of several family members in her had childhood acute abdomen because of intersusception. So the leading they have hematomas, jejunal and intestinal hematomas, so the leading point, and you have intersusception. Another patient, again, I had treated her and I had missed her syndromic diagnosis very early onset until one day she came without her lipstick and she had classical auricutaneous pigmentation. So later on, her mother and uncle developed, cancer. And this was again a Peutz-Jeghers syndrome because of STK11 gene. And if you had been doing only BRCA1/2, you would have never found a mutation. This just shows the type of syndromic. So breast cancer, we only think of BRCA1/2. In BRCA1, it is mostly triple negative and early onset. In BRCA2, most of them are ER positive and may occur even after the age of 50. In Leaf-Romani, most of them are HER2 positive. Peutz-Jeghers I showed, and Lynch syndrome. So based on suspect syndrome, based on type of cancer, ER, PR, age at cancer diagnosis, and decide what kind of testing is to be done, because subsequent advice could differ from cancer to cancer. So classical Hboc is what you think of early onset bilateral triple negative. It is not the most common presentation, rather uncommon, because you have incomplete unreliable family history, incomplete penetrance, 1/4 of mutation carriers do not develop cancer. And BRCA2 is generally not triple negative. Half the time it is coming from father side who's a healthy carrier, de novo mutation, and many other syndromes. This is I'm just showing, not to sort of as a make you nervous, that this is the estimated annual requirement for BRCA genetic testing and counseling in India. So you require, if you just look at the number of cases with breast and ovarian cancer and the age at presentation and the type of these histologies, you require 75,000 individuals who require pre-test counseling and 40,000 individuals on post-test counseling. So who will do this? At least as doctors, main aspects you should know what are the frequently asked questions and deal with. So this is our own data. Most of the patients who have BRCA mutations, they present with early onset unilateral or bilateral breast cancer. About 1/3 of them would have ovarian cancer. And in BRCA1, majority are triple negative. And this is the penetrance lifetime cancer risk. In BRCA1, we have a large cohort of over 800 carriers. Lifetime cancer risk is close to 80%, and the risk starts quite early in early 20s. In BRCA and ovarian cancer risk is a little less, for about 40 to 40%. I mean, here the confidence intervals are large, but I would say around 40% in BRCA1, and the ovarian cancer risks are middle age in mid-30s. For BRCA2, more or less same risks little lower, and the cancer starts at a little later age. So this is what the testing methods we were doing earlier. We did various ways. From 2007 we set up our own lab. We used to do Sanger sequencing, and then only hotspot mutation and affording patient in private labs outside. And now we are doing in-house multi-gene panel. So with different methods, you find different kind of mutation. I just show you in the last 1 year, we have done over 1,000 in-house germline multi-gene NGS panel. I'm only showing the Hboc cases. So we had close to 640 Hboc cases whom we did whole gene, the 26 gene panel. And you can see that in breast cancer, about 29%, and ovarian cancer, close to 40% cases had a pathogenic mutation. And you also get VUS, this orange bar, and you have to learn how to deal with the mutation, VUS carriers. And about 6% of all mutations are copy number variation, and they're not just in BRCA1 and 2, but other genes also, like mismatch repair gene, ATM, PALB2, P53, etc. I think once you learn how to deal with BRCA1, 2, then you get your hands onto the other genes. So what should be the approach towards a newly diagnosed breast or ovarian cancer patient or suspected breast cancer? So one is the diagnostic approach. You should have a higher index of suspicion for multicentric or bilateral disease. And if they're young or mammographically dense breast, order an MRI with a breast coil. And if the presentation is breast cancer, then no clear benefit of specific workup for ovarian cancer unless symptom, because generally it is not picked up, but you could do it. There's no harm, but it's not really necessary. In terms of treatment approach, discuss the indication for counseling and testing, and that the results may come after they have had the surgery or the chemotherapy has been started. It causes a lot of discontentment in the patient. They say that why did you start? Because cancer treatment will not wait for 1 month. Then discuss the safety of the breast conservation and special consideration. Discuss immediate or delayed contralateral prophylactic mastectomy with reconstruction and RRS. So at least those points have been brought out. And the systemic therapy options for BRCA mutation carriers or HR deficient tumors with platinum or PARP inhibitors. All these aspects you need to bring out. And I think this aspect will be covered in another lecture, so I'm not going into that. And in terms of the follow-up, encourage for detailed counseling and testing if it hasn't happened for the patient and the relatives, and lifelong surveillance. If RRSO was not done, emphasize that the limitation of ultrasound and CA125 screening, it can give them a false reassurance. Chemo prevention or risk reducing surgery as part of a study or evidence-based management, and I already mentioned. Now, if you have a healthy person who is at risk due to strong family history of carrying BRCA mutation, again, make them aware about cancer risks. Encourage counseling and testing, and then surveillance for breast cancer, monthly breast self-examination, 6 monthly clinical breast examination, and annual imaging. And as I mentioned, a limited role of ovarian cancer screening. So risk reducing salpingo-oophorectomy, all I wanted to say is that be aware that you may find an occult ovarian fallopian tube cancer in about 10 to 20% cases. So make them aware. And your pathologist has to carefully examine the femoral end of the fallopian tube, because the occult cancer could be there. And there is a small risk of primary peritoneal cancer exists. Now, Lynch syndrome, I'll very quickly talk about inherited colorectal cancers. You have polyposis and non-polyposis syndromes. Polyposis, mostly you have to see what type of polyps, adenomatous or hamartomatous polyps. So this is familial adenomatous polyposis. Here it is a Peutz-Jeghers most common type. So this is a spot diagnosis of polyposis, familial adenomatous polyposis. Important that there are many extracolonic manifestations, and so that you have to keep in mind. And this is our own data. So the most common cancer, of course, in this patient is the colorectal cancer, the carpet of polyps. And about 15% develop papillary thyroid cancer. And in our own data, about 1/3 of them develop desmoid. So I think as a surgical oncologist, whether you're GI surgeon or any surgeon, if you have a patient with aggressive intra-abdominal fibromatosis, you have to be really careful. And we have patients who have died just because of the complications of fibromatosis. So Lynch syndrome, again, it is more often it is a right-sided tumor, poorly differentiated, and most of them have no polyps, and that's but some of them may have polyps. It is because of mutation in the mismatch repair genes, MLH1, MSH2 being the most common, and IHC will show loss of these proteins, or if you have done PCR, you may have microsatellite instability. Extracolonic cancers are common in women. Endometrial cancer is quite common, and many other cancers. So this is our own cohort of Lynch syndrome. You look at the colorectal cancer risk, both for MLH1 and MSH2 is close to 70 to 80% lifetime risk, and the risk starts in early 20s. And endometrial cancer risk is also close to 50%, and the risk starts in early 30s. This is what I showed you about the Peutz-Jeghers syndrome, and we also found that most of these tumors had ER and PR positive breast cancer if they have breast cancer. Another syndrome medullary thyroid cancer is not just you look at the red mutation as to where the mutation is in that gene, and American Thyroid Association has classified mutation as low risk level A to very high risk level D. So the chances, the age at which they get cancer and the proportion of patients who get cancer depend on the risk level. And this is our own data. So this is one family where we could do testing for many family members and did prophylactic thyroidectomy for many mutation carriers. And in almost all of them, we could find a early stage microscopic medullary thyroid cancer. So prostate cancer, I just want to show you that how daunting it is becoming. I mean, if you look at NCCN guidelines, almost all the type of patient we see in our practice would require genetic testing. So high risk or early onset of metastatic. If you look at urological cancers, just look at renal cancer, testicular cancer. There's a long list of syndromes and genes. So this is an issue which comes. So as I mentioned, remember the Knudsen-Stewart hypothesis. And so first and foremost is genetic risk assessment referral. So individuals with a family history of cancer or in absence of a family history, if they had cancer at an age considered young for that cancer type, certain histological, molecular or phenotypic features that suggest underlying inherited predisposition. And I have not written here bilateral or multicentric cancer, so that is part of the Knudsen's. Just remember Knudsen as your god in hereditary cancer. Whatever he said, I think everything comes down to what the clinician said, just looking at some charts, like many people do in their thesis retrospective review, and through that he could deduce so much. So that is the power of human brain. It is not some machine that did that, just simple. Then pre-test counseling, it has to be detailed personal, social, and cancer history, treatment, and family history. Identify and address psychosocial issues. So ideally, someone has a significant family history or a young or you very high chance of having a mutation. All these issues should be dealt with in in great detail. I won't go into the details right now. Then for genetic testing, as I mentioned, use the most appropriate genetic test for that person. Use a lab with proven competence in that test and interpret test results and determine if it sort of explains or you need additional tests. And the post-test counseling is very important. So here I'm just showing various tests, screening tests in different cancers. Some of them have high evidence that they could help detect early and save lives, and others have weak evidence. So lab test could be a tumor marker or a fecal occult blood. Investigations, radiological, mostly an MRI for those who have a high risk for breast cancer, like in BRCA1 mutation or Lipfromery, this thing, and endoscopic for those who have high risk of bowel cancers. Chemo prevention generally for BRCA2 mutation carriers or bowel, the CAP2, CAP3 studies for aspirin. Preventive surgery mostly for breast cancer is data, and for ovarian cancer this is the only way, and adenomatous polyposis cancer, FAP, total proctocolectomy with IRA, and other. So this is a long list of syndromes and organs which are at risk, and you may or may not do. So because these are rare syndromes, sometimes the evidence is not very strong in terms of you ask for level 1 evidence, but based on the high risk of cancers and there are ways to screen them, you should screen them. The only screening method which is unreliable, which we often do, is screening for ovarian cancers, that you should be aware. Very often you miss stage 1 ovarian cancer. I'm now going to scare you. This is a very famous surgeon. So he was Dr. George Pack, very famous surgeon of New York. And so this case was filed by uh, Donna Safer. And in 1956, when she was 2 years old, when her father was operated by Dr. George Pack for a colon cancer with extensive polyposis. So the name itself is familiar, I don't know, polyposis. And both her father and Dr. Pack died in 1960s. And later, Donna was diagnosed with colon cancer and FAP. And she sued that my family was not advised about family screening. That's why I have this advanced cancer. And she sued because he was a very famous surgeon. He had a big estate left behind, and she sued. And even now, you look at a lot of genomic malpractice cases are happening. And I hope some of you would not face these cases, but I won't be surprised that if some of you face, because this is a landmine and you can't avoid it. You have to walk this path. Just see this, what happened. This was in the Washington Post. This lady, damaged for the rest of my life, woman says, surgeon mistakenly removed her breast and uterus. I mean, how on earth could this happen? But the nurse misread her BRCA genetic testing result as positive, conveyed it to the surgeon, and the gynec and breast surgeons performed. So you have to understand the report yourself. You cannot rely on what someone has. So positive could mean a mutation, or positive could mean it's a normal report. So you have to understand that. So what Voltaire said, the perfect is the enemy of good. So perfect is a well-developed referral system, pre-test genetic counseling by a genetic counselor, comprehensive NGS multi-gene panel testing, and with MLPA, post-test genetic counseling, then risk prevention screening, precision medicine is applicable. So this is what should happen. But many people, because they're so scared of what could happen if you don't do this, they don't start the service. But you have to start. And what is important, that good is also possible. So at least as an oncologist practicing, you can identify patient with more than 10% probability of a germline mutation. So whenever Nutson's is there, take into account. If you don't have access to a genetic counselor, learn to make pedigree, know what are the frequently asked questions and the aspects of at least the common hereditary cancer syndrome, which is Hboc, Lynch syndrome, and Lee syndrome. And if the family cannot afford multi-gene panel testing, consider hotspot and founder mutations. And there are, I've not shown the data, but there are founder mutations in Indian breast cancer patients, or limited testing and prevention and screening methods known to reduce cancer morbidity and mortality. So I was talking about founder mutations. So there are many mutations which are particularly common in some genes, and like this I'm showing BRCA gene in specific regions or communities. So if you once you know that, you could use them. This is what is happening. Like for ovarian cancer, they're saying every high-grade epithelial ovarian cancer needs genetic testing. So the traditional path was that every patient, traditional BRCA testing pathway, every case was referred to genetics clinic, say 6,500, and then if a mutation is found, then they would follow up with the genetics clinic. Otherwise, they go back to their testing. Whereas, and that was not really working. The genetics clinic becoming a choking point. So the clinicians learned the main aspects. They order the test, and on the results, if it shows a mutation or a BUS, then those cases are referred, or if anyone has a significant family history. So my colleague Rima, she did a little survey, and what we found, the reasons for not referring patient for testing amongst the oncologists and TMH, and almost half of them said lack of physician awareness. And I hope after this lecture, you will not say that lack of awareness, lack of time, infrastructure, the cost, and the turnaround time. All these are important. For no other test, you wait for a month, except for a germline genetic test. And There are many other reasons. So with this, I will end, and we a lot of patients and opinions, second opinions. We do telegenetic counseling also at Tata Hospital, and we have over now we will be having 11,000 family in our genetics clinic very soon. Thank you very much. I'll be happy to answer your questions.
Thank you very much, Dr. Rajiv Sarin. Our trainees, you may type your questions, comments in the chat box.
Thank you very much. That's a good, fantastic talk, very nicely analyzed. Now the importance of pre-testing counseling, because most of the time we actually find once you do the test, a good pre-test counseling is not done. We don't have a luxury of even post-test counseling with us.
Yeah.
But we understand that now, because like mushrooms, lot of NGS companies have started everywhere. We are finding another sort of irony now. There was no test till now. Suddenly, last 1 year, every lab want to do it, and then clinician just don't know the impact of it, and you get as a VUS, not actually a actionable mutation, but then we are in big soup because we are not counseled, and the agony in the patients is unbelievable. So can you just, for the benefit of student, throw little light on importance of pre-test counseling?
So one is a pre-test counseling. As I said, if you have the luxury of having this thing, so that at least for the common syndromes, you may not do for a rare syndrome, the like Hboc, Lynch syndrome. You should know if you are suspected. You say we suspect that your cancer or the cancer in your family could be of the genetic type. There are ways to confirm this if we do the germline genetic testing, but that may or may not confirm. The result may be negative that we suspected we did not find. It may find a mutation and sometimes it finds a change about which, as of now, scientific knowledge is insufficient. And then we tell them if it is of the hereditary type, there's a possibility other members in the family could also have inherited this. And if that is the case, then they will need to be explained. And if they agree, test them. And if they are found to be carriers, we guide them that their cancer risk is managed. So once they understand, then they agree. And if then the confidentiality issue, sometimes even within family, so much of it is hidden. So that privacy and confidentiality, and we explain to them. And practicing doctors can explain complex things in few minutes. You don't have to spend 1 hour that because you already know that patient, you know what are the concerns of that patient. That is one aspect. The second point which you raised is very important. The NGS labs are mushrooming. So I mentioned twice, thrice. Use a lab with a proven competence and also right reporting format. I have seen genetic testing reports from NGS lab. It looks like they have been written to confuse doctors. Okay, they are like, I mean, I don't know why they write. So see, because the lack of expertise, sometimes they have not done clinical reporting, and the pathologist is there. Pathologist has also never done, and someone else from the genomic lab. So you have to see whether they're writing pathogenic mutation or not. I have seen report who have written 11 mutations in BRCA1 and 2 in BRCA2. I said, how can it happen? Someone having 13 mutations. They were basically describing SNPs, polymorphism. And for every polymorphism, you will have a scientific paper. Someone has published showing the risk association. So basically, it increases your relative risk. So 1 OR or RR is 1.3, 1.5. That means instead of 4% lifetime risk of breast cancer, your lifetime risk of breast cancer is 6%. That is not the mutation we are looking for. We are looking at high penetrance mutation. So see, if they have cited a reference, it is a high penetrance germline mutation. Don't act upon polymorphism. In our own hospital many years ago, a little child was just about to undergo a prophylactic thyroidectomy because one of the prominent labs in the country had reported a red gene mutation. It was not a pathogenic mutation, but a polymorphism. So before you act, especially if you do a preventive surgery, you be absolutely sure that you're acting on a pathogenic mutation and it is not a VUS or a this thing. Even if you start a treatment which is like a immunotherapy or PARP inhibitors, I have seen patients who have been on PARP inhibitors for polymorphism in BRCA gene or VUS in BRCA gene. So it is very important.
Fantastic, fantastic. Vishal Mukherjee has asked, sir, we quite often get this VUS. How do we really interpret with about VUS and move on? Because it's neither a normal return nor they're able to characterize. Quite often we see VUS. So how do we interpret and how do we move forward?
So the first thing is, if you should have said you have looked at that syndromic differential diagnosis, okay? Like if it is a triple negative breast cancer, you have ordered because the early onset triple negative breast cancer, no family history. And if you find a VUS in the APC gene, that's become very straightforward. So APC gene, if it was a disease-causing mutation, then you don't get triple negative breast cancer in that. And in APC carrier, by the time that lady is 35, almost always would have polyposis and have a family history. So in absence of any FAP associated phenotypic features or family history in a lady who has a triple negative breast cancer, you say, well, this gene is not relevant for you. So look at the gene which is relevant for that suspected syndromic feature. Whereas if this APC VUS I had found in a patient who has colorectal cancer, then the first thing I would immediately want to know, does the patient have polyps? Like just recently we had a case, we finding a APC mutation and no polyps were mentioned. We found a germline mutation, this thing. But then it was mentioned that because it was obstruction and the colonoscopy was incomplete, that's why it was not documented. So first thing is you look at the gene in which the VUS has been found is relevant or not. So that is one thing. If the gene is relevant, suppose someone has a triple negative breast cancer case, I mentioned you are finding a VUS in BRCA1 gene. Then you look into the little more details. Okay, then you read about that VUS, how they have described. And over a period of time, the VUS, if it is done, reported in a good lab, if they're calling it VUS, that means no one really knows what it is. Then based on the family history and personal history, you counsel them, but still don't go ahead and do preventive surgeries. If you do that, that advice should come after a second opinion from a high-risk clinic. So don't act upon a VUS, especially major action points, without having a second opinion and you see whether the VUS is of relevant gene or irrelevant gene, and what are the fine prints written under the description of the VUS.
Absolutely, that's that totally I agree. If you want to really take a drastic step of intervention, which is life changing for a person, remember they're not patient, they're normal person who may or may not develop. So you have to have a qualified, proper genetic counseling session and then agree upon and then proceed. There is one more question. Now that in endometrial cancer, huge amount of, now the whole thing is on genetic. So MSI and then Paul and all are come. So how do we go about genetic testing in endometrial? At least in breast and ovary, now we very clearly know as per the NCCN and various recommendation when to ask. What about genetic testing in endometrial cancer?
So genetic testing, I'm talking of germline genetic testing. So like in colorectal cancer, the IHC for the mismatch repair protein should become routine, especially if they're under 60. Okay? And in anyone who has a family history. So that is one thing. And once you have endometrial cancer, then they need multi-gene panel testing, at least the mismatch repair genes. And one more point I would say that sometimes the EpCAM gene is not included. It could be deletion in EpCAM. So MLH1 and MSH2 are the most common. Then MSH6 and PMS2 and EpCAM. So should do it. And the family history is important. Sometimes doctors don't take family history in patients with endometrial cancer. For ovarian cancer, breast cancer, more often we take a family history, but for endometrial cancer, many times they were operated by a gynecologist outside. So the family history is not taken. And this it could be a marker cancer for the Lynch syndrome. And this is very important.
Thank you. As usual, Kishan is suddenly asking, sir, is there any small handbook on this topic we can read for exam? Students love these notes.
Small handbook, unfortunately,
I wish life was so simple.
Yeah.
So no shortcuts, nothing can be learned with a small handbook. But anyhow, I know I'm happy that this is a platform where students are encouraged to ask anything to the leaders. But sometime, so the answer is there's no shortcuts. Please attend webinars like that. Go back and read. It's impossible. Anything can be put back, especially a topic like this. Yeah, two people have asked, Dr. Ravi and also Neetu. Sir, can you please explain us about NGS and its specific indication? So we'll keep it simple because we have new first year students who have joined now just this week. So a lot of them are there, and I really want them to know. They're asking, sir, what is NGS? What are the indications? And please, can you explain few more words about it?
Okay. So NGS stands for Next Generation Sequencing. So, Frederick Sanger from Sanger Institute got the Nobel Prize for showing how to do Sanger sequencing. Sanger sequencing shows, there was a method, dideoxyribonucleic acid, to show what is the sequence of the nucleotides in that stretch of DNA. So we know gene, we know what is the reference genome, like in BRCA1 gene or P50C. This is a sequence in which nucleotides are arranged. And to know that sequence, so sequencing is to study that sequence of nucleotides. There was a Sanger sequencing traditional method. It was a painstaking, that is how to do by capillary electrophoresis. One after other, we know that A, T, C, G, G. So it is to take time consuming and cost also. And you would only test one gene or part of one gene, at the most two genes. Okay? Myriad Genetics used to charge $3,000 for doing BRCA1-2 genetic testing. And some of the mutations, like what we call large deletions, will be missed by Sanger sequencing. There used to a method known as MLPA to detect that. Now, about 15-20 years ago, a new method came, which is known as next generation sequencing, in which the whole sort of genome is shattered into small pieces. Then there is a process in which you prepare a library. Suppose, so what we do, resequencing. So suppose I'm interested in 10 genes or 30 genes or 100 genes. I know what is the sequence of those genes. And because so there is a complementarity like AT, GC, how they complement each other. So I will have design probes and library. I will select those genes, the coding region of those genes that I want to sequence, and amplify them. And in this machine, now the most common method is Illumina. These are different companies. Illumina is a company, there's iTorrent, then there are Roche, 454 different next-gen sequencing sequencers. In that, what you do is the same, because you have broken into pieces. Every fragment will be sequenced or read. That means the sequence of nucleotides in that fragment would be read 100 times, 200 times, 500 times. So now later on, it has to be all stretched, put together, as to know, okay, this is a whole, because you have broken them into small pieces like a jigsaw puzzle, and there are methods, bioinformatic pipelines or tools. It is all stretched together and then it is read. So for every point of that gene, you will know whether it is A, as it should be in the reference genome, or it has changed to C, or the A is missing. So once you do that, then this whole process you can do faster, you can do at less cost, and because you can do it more efficiently, you can, instead of just testing one gene, you can test 10, 20, 30, 40 genes. And there are bioinformatic methods through which you can also detect if parts of the gene are missing or duplicated, what we call large deletion or duplication. So copy number variation. So next gen sequencing allowed more powerful, faster, and reliable germline genetic testing, and also tumor somatic genetic testing. So that it has allowed, it is quite mature. It's a diagnostic test, and it is also used in research. Like as part of the International Cancer Genome Consortium, we are looking at the whole exome or whole genome of oral cancer or some other cancer. So it is used both for diagnostics as well as research.
Also, students, now that you have joined newly into the program, 3 more years you'll be trained in cancer center. Remember now, the recurrent cancers, metastatic disease is one place where either you can use a liquid biopsy blood or a tissue and we do NGS. And remember, now there are places where we do germline mutation and then followed by somatic. I'll give an example, like in ovarian cancer, if you have an ideal facility to check whether that patient has BRCA1, BRCA2 mutated, you want to give a PARP inhibitor. If you have a tumor tissue and blocks, you do a somatic. If that is not there, then you go to germline. If that is negative, then you can ask for HRD. This is the sequence. There are some places where PARP inhibitor is recommended both based on the somatic, like in ovary and pancreatic and prostate. In case of breast, purely based on the tissue block somatic, it has not come. So it's very important to read more about liquid biopsy, ctDNA, and tumor cells and NGS. We'll arrange more classes, and you will get you can sort of get it. There is one more question. Should we go for hypermethylation testing if MLH1 gene comes positive? And what does it indicate?
So, it depends. Actually, if MLH1 and MSH2 both are not expressed in the tumor tissue, so MMR deficient. The first, if this has happened in a young patient or a family history, then definitely you should first go for germline genetic testing. If it has happened in an older person, no family history, no other feature, then you could do first rule out hypermethylation, because that could be one mechanism of loss of expression of MLH1. And if that is negative, then do that. But what we have found in our this thing, if you do a good IHC, which is using a validated IHC, this thing, if you see loss of this thing, germline genetic testing we do first, and we find mutation in 70 to 80% cases. So if you do not find a germline mutation, then you do for methylation studies. But in the context also, if it is like the elderly person, no family history, then you could do first this thing. So we also look at the clinical context.
Superb. The beauty of this, your talk is, Arpita is asking, sir, after we complete our super specialty training in onco, is there any genetic course we can pursue after super specialty? Please suggest. We'll put it in nutshell. Sarini, is there any genetic course under you for our, oncology students who complete super specialty training?
So many people come for short-term training. The course, I mean, I've been, toying, and I've been people are asking to start a, DM in cancer genetics. Maybe one day it'll be required. Today we don't have, but short-term trainings are there that way. And I think only once our genetics clinic is so busy. Even if you spend 2 weeks there, you would have seen almost all syndrome, several times.
Fantastic. All good things have to come to an end. There will be question pouring, but as I always say, we are not here to spoon feed the student. We show them the path, we stimulate their mind, and we let them know they have to walk through, read, and then interact and meet you again in the conference or personally to get it.
Yes.
Questions are keep coming, but I have to end this. That shows the importance of this and the way beautifully you ignited the minds of our students. Thank you very much. My heartfelt thanks from myself, the NBE board, and also students. Beautiful. You're a wealth of a knowledge. 10-15 times we have to call you back and interact to get 1% of what we can understand. Thank you very much.
Okay. Thank you very much.
Thank you very much, Professor Dr. Rajiv Sarin, for the presentation, and thank you very much, Professor Dr. Somashekar, for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.